Hi, and welcome to the show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Poe, founder and editor of Kevin MD. Today on the show, we have Renee Gonzalez. He is an anesthesiologist, and he wrote the Kevin MD article, Surgical Smoke Evacuators and Inertia in the Time of COVID. Renee, welcome to the show.
Thank you very much, Kevin. It's really a pleasure to be here.
So we'll get into your article in a little bit, but first off, can you share your story and your journey to where you are today?
Absolutely. So I am an anesthesiologist, and I've been practicing anesthesia for almost 35 years now. And on the afternoon of, I live and practice in New Jersey, in southern New Jersey. And on the afternoon of Saturday, April 4th, I remember that day very well, because I had been in front of my computer reading up on all of the sad accounts, really heartbreaking accounts of my colleagues throughout the world that were in hot zones with the COVID pandemic and some of their attempts to deal with it and some of their failures. When I got an email from my medical center announcing that it would be honoring the recommended moratorium on elective surgical and medical procedures for the upcoming weeks, effective a couple of days later on Monday of the following week, in order to try to conserve healthcare professionals and also critically short supply equipment such as surgical masks, N95s, rubber gloves, etc. I think that was a great idea, but I continued to read on, trying to understand more about the mode of transmission of COVID. Mm-hmm. And that evening, I spent the evening watching YouTube videos on some of the innovative ideas that my colleagues were using around the world. And one of these were what's come to be known as intubation extubation boxes. They were constructing clear plexiglass boxes, cutting armholes into them and placing them over the patient's head and torso in order to be able to manipulate their airway. People like me, anesthesiologists, emergency room physicians, critical care docs, and frontline providers, we don't have the luxury of social distancing. And we also can't practice the principle of source control by having patients wear surgical masks. We have to remove patients' masks and be close and personal as we intubate them, as we extubate them, as we apply respiratory treatments. All of these are aerosol generating procedures. That day, I also remember seeing some very well-made simulations on YouTube of the spread of the aerosol cloud produced by patients coughing and how it could spread for meters, actually. So I went to bed that night pretty troubled, honestly. And as I was falling asleep, I had a recollection of something from my days when I was the chief anesthesiologist at the Eye and Ear Hospital at the University of Pittsburgh. And that's where we did all of the ENT cases at Pitt. We had the largest ENT department in the world at the time there, and I believe they still do. We also did all of the plastic and reconstructive surgeries there. This was in the 1990s. I had noticed that some of the plastic surgeons were using a device called the Surgical Smoke Evacuator when they were removing genital warts, papillomas. And I inquired about the reason, and the reason was because there were case reports, quite a few of them, of surgeons developing genital papillomas around their faces, around their mask lines. And the reason was because when they used the laser or the electrocautery, the BOVI, to excise those lesions, active papillomaviruses get released into the plume of smoke, and they contaminate surfaces, including personnel. So we also we were doing a large number of excision of laryngeal papillomas by the ENT service, and we're facing the same problems. So I got together with our hospital engineer, with the ENT leadership, and we created a protocol for that, as well as for all of the plastic excision of genital papillomas, whereby we would simply place the surgical smoke evacuator near the patient's airway for ENT excision of laryngeal papillomas, and it would dramatically capture all of the smoke that was coming out of the patient's airway that was potentially contaminated with papillomavirus. This became protocol. We adopted it and used it on all of our cases. And this was the idea that came into my mind that Saturday night of April 4th. These surgical smoke evacuators are FDA-approved devices. They basically are very simple devices, really, very sophisticated, but very simple. They consist of a very powerful negative pressure air pump that actually collects up to, or a minimum of 25 cubic feet per minute of air. And then it's attached to a very effective filter, which many people in medicine have never heard of. It's called an ULPA filter. Now, that's ULPA, or ultra low particulate air filter. Most of us have heard of and use HEPA filters, high efficiency particulate air filters. These ULPA filters are an order of magnitude more effective, especially against tiny particles in the 0.1 micron range, which is exactly where the coronavirus lives. Coronaviruses are approximately 0.1 to 0.12 microns in diameter. So it occurred to me that this could be potentially a great idea in the battle against and in the war against COVID in the operating room and in critical care areas. One of the problems was access to these devices. Mm-hmm. And I woke up the next morning and remembered that in my current operating room, we have a surgical suction device. This particular one, there are many manufacturers of surgical smoke evacuators, but our surgical fluid suction device, which the surgeon uses for suctioning blood and fluids from the field, actually, they all contain a surgical smoke evacuator. And these are devices that are on wheels and portable, but we have one in every single operating room. And they're relatively underutilized. They're used by the surgeons as they bovie. Now, many organizations, including the CDC and the American Association of OR Nurses, have recommended the routine use of these surgical smoke evacuators for several decades now, not only for capturing viruses that could be released into the air, but also for capturing chemical substances that result from the burning of human flesh by electrocautery and laser, and can be quite toxic and have ill health effects. I think there have been estimates that working in an operating room is tantamount to smoking something like multiple packs of cigarettes a day. And if you've ever gone into an operating room, you know that there's often the smell of burning flesh. So my pretty simple idea was I called a couple of colleagues, former colleagues from the University of Pittsburgh that had gone elsewhere, and I asked them about their institutions, and they had these smoke evacuators built into their surgical blood suction units in every single one of their operating rooms, 3 different institutions, 3 different states. So these devices are out there, they're FDA approved, the capital expenditure is already made, and they're being relatively underutilized. They're only used during the surgical part of the procedure, but they're considered surgical devices. They are purchased under the surgeon's departmental budgets, and they're managed by the operating room nurses. It's very, very interesting that in April, the Society of Gastroenterologic Surgeons came out with a paper recommending the use because COVID can also exist in the alimentary, in the GI tract, and in feces. And so they were recommending the routine use of this for all endoscopic surgery to try to prevent COVID from aerosolizing into the air and being transmitted to healthcare workers. So that was the crux of the idea, to use surgical smoke evacuators basically as a personal air scrubbing system. And the way to do it is very, very simple. It can be simply held by an assistant or by a stand, such as the one that we use for our anesthesia breathing circuit tubing, or by a clamp device near the patient's airway during intubation, extubation, while the patient is coughing, to reduce the viral load that can contaminate not only the anesthesiologist, but also the surgeon, the scrub nurse, the circulator, and the housekeeping people that are charged with cleaning up after the patient leaves the room. And we see often, particularly after endotracheal extubation, patients cough for prolonged periods of time, and they're generating these aerosol clouds that can be very effectively swept up and safely controlled by the use of a surgical smoke evacuator.
Now, are these surgical smoke evacuators, are they now routinely used in your medical institution?
Well, I retired from clinical practice this summer, coincidentally. I've been advocating them, and some of my colleagues are using them routinely. There's been a little bit of inertia regarding the adoption of this, and that's one of the reasons I wrote the article. It's been a little bit surprising, but I call it a COVID-related inertia to the adoption of a new idea.
Now, what are the sources of pushback against this idea? Why aren't more institutions implementing it?
You know, Kevin, that's a fascinating question. I think a large part of it is simple lack of awareness of these devices. As I said, they're considered surgical devices and that are managed by the operating room nurses, and many anesthesiologists therefore don't really involve themselves very much with the use of these. They're used by the surgeon, by the nurses, and I guess it hasn't occurred to them maybe that these could be used, placed near the airway and used as air cleaners for to control aerosol cloud. I think that's an important one. As far as emergency room docs and critical care docs that face the same problems that we do with managing airways in close proximity to the patient's airway, I think since they spend little or no time in the operating room, they're simply unaware of the existence of these devices. Some other interesting factors, I've given a lot of deep thought to some of this inertia. I think another one is the fact that there is an overload of COVID-related information, not only in the medical journals and the online journals, but also in social media, in the mass media, and it's a lot to take in and absorb. I think there are also other very, very significant and very legitimate COVID distractions, COVID-related distractions. A lot of anesthesiologists right now are very concerned about their practice finances because that long moratorium that we had on elective surgery and on elective procedures really created some significant financial problems for groups, and they're scrambling to try to deal with all of that. So I think those are some of the reasons.
And as far as you know, are any physicians or institutions in the world using surgical smoke evacuators in the way that you describe?
Well, like I said, ENT programs are probably using them for laryngeal papillomas. The way that I described, I was using them, and then some of my colleagues in a couple of other institutions were using them. I have no way of knowing who is actually using them now. I have tried to get the word out there. And some of the other interesting reasons for this inertial phenomenon that we've seen. So I had my idea on a Saturday evening, April 4th. I wrote my first paper on it that Monday. Actually, I started Sunday and submitted it, and actually submitted 2 papers on the topic to one of our specialty journals that is very much concerned with patient safety. After editing, they accepted them about a week later, so we're talking middle of April. They didn't wind up getting published until August or early September. And I believe that is, again, because of the COVID information overload. A lot of the editors on staff are also clinicians themselves and we're in big cities, and we're facing the same COVID crisis that the rest of us are facing. So the traditional medical journals, I don't think, have been able to catch up, especially in the early phases of the pandemic. I think they're still moving pretty slowly and haven't been able to catch up. Some of the journals want prospective, randomized, controlled studies, full scientific method, and I am completely in favor of the rigid scientific methodology and evidence-based medicine. However, observation and inferential logic, I think, can also go a long way, especially in the middle of a pandemic. We don't exactly have resources or manpower to be conducting a lot of clinical studies as we're suffering with this pandemic. And again, I go back to, this is based on personal experience using it for ENT purposes back, when I was at the University of Pittsburgh, and also the hard specifications, the specs that the FDA has approved that these manufacturers rigidly adhere to for these machines.
And to be clear, the majority of medical institutions today in the United States, they have these surgical smoke evacuators in pretty much all their facilities.
I'm thinking that that's probably the case, certainly based on sampling my colleagues and my own personal experience, because just about every operating room has a surgical blood and fluid suction device. And as I said, many of them have devices which have built-in SSEs. One of the other functionalities of this idea is that they're also small, very portable. The surgical smoke evacuators that I mentioned in my operating rooms are in a larger unit that is on wheels and can be transported to the recovery room if a patient is coughing or needs to be reintubated. Could even conceivably be transported to or placed in an emergency room, an ICU, COVID unit that a hospital has to set up, but there are even smaller devices by other manufacturers that are very portable and can be used for the same reason. And I think, Kevin, I also think that perhaps people are misunderstanding my idea here, in that this is not meant to be a substitute for N95 masks or upper respirator systems, or eye protection, or the operating room ventilation system. It really should be viewed as an additional adjunctive. One more fact. Some of the other lines of defense that we use are pre-op COVID testing, but interestingly enough, for elective procedures. Interestingly enough, initially, a lot of institutions are saying, well, we'll demand that every patient get tested for COVID before elective surgery 1 to 2 days before their procedure. Then they realized they couldn't get the results back in time, so they pushed it back. They loosened that standard to 2 to 4 days before. Some institutions are doing 5 days pre-procedure. Well, we also know that there's a 10 to 30% rate of false negatives with COVID testing. So COVID is certainly not 100%. And the longer, the farther out in advance of the procedure that a patient is tested, they have many days to potentially become COVID infected. And in fact, one of my colleagues, shortly after they reinstituted elective surgery with mandatory COVID testing for all patients, one of his colleagues and the anesthesia resident that were assigned to a particular case both came down with COVID. The patient had tested negative preoperatively, had his surgery, a few days later presented to the ER with severe respiratory symptoms, was COVID positive, and both the anesthesiologist and the resident that took care of that patient wound up converting to COVID positive. Anecdotal, but again, not surprising. N95 masks are not 100% effective. None of the measures that we use, even the promising vaccines that are on the horizon, we're excited when we hear they're 90 to 95% effective. That's also 5 to 10% lack of effectiveness. So I think the more layers of defense that we have, the safer our personnel are going to be.
We're talking to Renee Gonzalez. He's an anesthesiologist, and he wrote the Kevin MD article, Surgical Smoke Evacuators and Inertia in a Time of COVID. Renee, you said that a lot of procedure-based physicians may not be aware of surgical smoke evacuators. Now, where can they find out more information about it? Who can they go to the hospital to learn more?
Okay, well, I would start by going to the operating room nurse manager in the hospital and asking which units they currently have in their operating rooms. And then you can contact the local reps. You can research this online very easily. Most of as I mentioned, there are multiple manufacturers of surgical smoke evacuators in the United States. And I think these devices are used worldwide, especially in the more developed nations. So I think they are a lot more, again, I think they're sitting right there in front of our eyes and we don't realize they're there. Another concern, people have said, well, what about the expense? And I say, well, the only expenses are, since if your hospital has these devices, the only expense is the disposable suction tubing. And what I recommend is the 7/8 inch tubing, which is the widest diameter, like more of the aerosolized contaminants. And that's about $4 or $5 with this per use with the system I use. So the way I envision it is the anesthesia providers can use the SSE in the beginning of the case during intubation until the airway is secure. They can turn it over to the surgeon to use during the duration of the case for surgical purposes. Then the surgeons hand it back to the anesthesiologist to use at the end of the case, peri-extubation. Another concern, the only other cost of disposables are the ULPA filters. And in the Stryker Neptune units that we use in my operating rooms, these have 80-hour run times. And the ULPA filter canisters are only about $200 each. And that's 80 hours of continuous runtime. That's a lot of cases. So really the expenses are very, very minimal compared to the expense of getting a provider or housekeeping person or a nurse sick, taking it home to the family, spreading the virus. The other concern I think that people may have is that this is some complicated piece of equipment that they don't know how to use. Again, it is literally as simple, Kevin, as plugging in the disposable tubing, turning the machine on, and holding the end near the patient's airway. And it's really, and then turning it off at the end of the case. And of course, disposing of the disposable tubing in an appropriate manner so that you don't contaminate the environment.
And my final question, Renee, what's your take-home message that you want to leave with the Kevin MD audience?
I would say that in this war against this invisible enemy, which creates these invisible clouds every time a patient coughs or every time we perform an aerosol generating procedure, first of all, we should be open-minded. Second of all, we have equipment sitting in our midst that's already paid for with very little additional expense in terms of disposables that can help us as an additional line of defense as healthcare providers who cannot social distance, and we should seriously consider using this as an adjunct. None of the current personal protective strategies, such as pre-operative or pre-procedure COVID testing, N95 masks, PAPR respirators, eye protection, and even vaccination that's coming down the pike, none of those are 100% effective. So if you imagine yourself as a soldier going to war, and I give you one more piece of equipment that can help you save your life or save the life of your buddies or your loved ones, I think it makes sense to pay attention. And again, these are already FDA-approved devices. They have been in use for decades. They are tried and true. And I think it could be a really, until the studies are done, I think they could be very, very useful adjuncts to our current strategies against COVID.
Renee, thank you so much for your time and insight. And thanks again for being on the show.